Daryl Moon is a friend. I've known Daryl since, I don't know, 2014, when he first told me that that everything that we were thinking about addressing mental health was wrong. That that in fact low-grade addictive behaviors that end up being the root of almost all of the downstream costs that we have in healthcare can be addressed by going after seemingly minor things like loneliness and self-efficacy, and that he had proof points around all of this because Daryl used to run mental health hospitals, and he ran get this, a capitated behavioral health HMO, meaning they handled start to finish all behavioral health and fully capitated. So he was day in, day out managing the costs that handle and go along with all mental health diseases. So he knows mental health cost better than any person I've ever interacted with. And I was so excited to get him as a speaker today. He publishes in Forbes regularly and speaks before CEOs all across the country. One of the foremost experts in behavioral health, and especially its linkage to cost and physical health. Thank you so much, Daryl, for joining us today. Over to you.
Thanks, Lee, and it's a pleasure to be with you. Thanks for the privilege of joining this webinar. Am I coming through okay? Can you hear me all right? Awesome.
Great.
Okay. Well, we're going to talk today about behavioral health and how it improves population health. Next. The most important thing that any organization needs to decide is, what is their goal? Is the goal to provide medical treatment, or is the goal to improve health? Next. And I would suggest that our healthcare system that we know today is primarily focused on the first, which is to provide medical treatment. And I'm going to let that sink in just a little bit, because that truly is what employers are generally doing, is they're simply paying for medical treatment. They're providing medical care. And that's the goal in a lot of cases in terms of what we're currently buying. One of the foremost healthcare providers in this country really leading this movement towards better overall health and managing costs, both mental health as well as medical care, is a company called ChenMed. And the founder of ChenMed has written a book called The Calling. And I think he spells out some of these principles as well as anybody I've heard from. So I'm going to share with you just a few things in the book, The Calling. And he starts off here but under the standard methodology of healthcare, most physicians are trained to offer transactional healthcare. I've been trained to transfer the knowledge that I've gained to my patient. Once I've done that, we're done. The doctor is then paid for the number of those transactions she or he performs. And that's pretty much what we buy in healthcare. Next. And if that's what we're buying, if that is what we want, is to provide medical treatments, medical science is front and center and the most important thing. And that's why medical science is pretty much the forefront of our current healthcare system. Next. But the question I love to ask CEOs when I get in front of a group of CEOs is, what do you want? What we're currently buying is insurance to pay for those medical treatments. That's what we're buying. But what is it you really want? As an employer, as a CEO of a company, why do you buy benefits? Next. And it's interesting, over 1,000 CEOs I've had an opportunity to ask this question of in a very personal way and with a lot of time. And here's what they say they want. They want to attract and retain top talent. Number one reason why they offer benefits. They want a healthy, productive workforce. They want their employees satisfied with and to understand what their health benefits are. And not least of which is, I wish it cost less. That's what I want. But it's interesting when you ask employers, okay, are you measuring to see if you're getting that? They say, no, I guess not. And then when you say, are you incenting anybody in the system to help you accomplish those business objectives? They say, no. Like, does your internal team get incentive to help you actually accomplish those 4 business objectives? No. What about your entire workforce? Is everybody incented and motivated to help you reach those objectives? No. What about your consultants? Are they aligned with you to help you accomplish those? No. And then I ask them, so whose problem is this to solve? Who's really at fault as to why our healthcare system's so broken? Anyway, next. So if in fact the goal is to improve health, which I hear from business leaders all over the country, that's one of their primary goals. You have to realize now the behavioral science is actually more important than the medical science. And simply put, I can create the perfect treatment plan for a patient, but if that patient doesn't comply and actually implement the plan, what good is the plan? Behavioral and engaging people in behavioral change is actually more important than the perfect treatment plan. Next. In the book, The Calling, Dr. Chen says as well. He says, we have designed our care to inspire behavioral change within our patients. We desire better outcomes than merely alleviating symptoms of disease. Next. And one of the best examples of how this is working so effectively is many of you may have heard that Humana is leaving the commercial health insurance industry business. You might ask, well, why? Well, Medicare Advantage is far more profitable for them. And you might say, well, how in the world can having to take responsibility for the sickest population, the seniors, be more profitable? Well, it's quite simple. They simply pass on 100% of the risk to companies like ChenMed. And then ChenMed, who's paid a fixed amount of money, Humana just simply takes a profit margin, hands over the money to ChenMed. ChenMed takes complete risk for all healthcare expenses, mental health and physical, for that senior based on a certain capitation per month per senior. Next. In The Calling, Dr. Chen says, this is important, we want to hear seniors articulate their health goals. Give them the tools they need to reach those goals, and then coach them to better health. This requires relationship. We have to find physicians who are willing to learn about behavioral and lifestyle change and how to develop caring relationships with their patients, and ones who are humble enough to consider receiving additional training. Next. The design was for every doctor to see every patient every month. And the top limit for the number of patients in their panel would be set at 450. I'm going to let you think about that for just a second, because that's not how healthcare works. Imagine taking on the financial risk of seniors. And how did they do that? And how were they effective? Because they assigned every primary care physician only 450 patients at the most, and every patient gets seen virtually or in person every single month. That builds relationships. When they're seen every month by their PCP, the patient feels cared for, and they call their physician when something happens immediately at the very beginning. If they're sick, it gives them the hope that they'll get better because they have this relationship with the provider. This is an important part of getting and staying well. They're more likely to follow through on what the doctor asks them to do as well. Engagement. Next. So what are their outcomes? Well, companies like ChenMed and other companies that Humana contract with, this is all per Humana, like CenterWell, they're seeing profits of 25 to 35% under a model where they're taking 100% of the risk of the most sick population in this country. And they're doing it through relationships and by putting behavior in front of medical science. Behavioral science is actually more important than medical science. Next. Now I'm going to tell you about the best healthcare system in the world. I find across the country that very few people know that there's actually a healthcare system out there in the world that we can put on a pedestal and say, there is the best model of healthcare anywhere in the world. And it's called the NUCA system of care. Next. It's
in the United States.
It's right here in our own backyard. It's in Alaska. The interesting thing about the NUCA story is that they're the only healthcare system who actually built their system on asking the customer what they wanted. Imagine that, building healthcare based on what the customer wants. Well, when they had the opportunity to build this system, they started up about 20 years ago. They did a massive survey asking their 70,000 Alaskan Native people that they were responsible for their health, what was it that they wanted. And what they heard from their members was, we don't want a paternalistic system that simply tells us what to do. We want a healthcare system that journeys with us through life, helping us reach our aspirations. I'm going to sit there and let you think about that for just a second. And think of how completely transformable that would be if healthcare actually, as its primary goal, was to journey with people, helping them live life to its fullest and reach their aspirations. Very different than what our current healthcare system does. Next. They built what they call a behavioral-focused, relationship-based healthcare system wrapped around the customer. In fact, they refuse to call their members patients. If anybody does, they're let go. It's like every patient is not called a patient. They're called customer owners because their healthcare system is literally built for and around the needs of their customer owners. They consider them the owners of their system. Next. They are the only healthcare system that has won the President's Malcolm Baldrige Award twice. They reach 98% patient satisfaction. And they don't even call it patient satisfaction, they call it customer owner satisfaction. They reach 93% employee satisfaction. They used to be, when they started 20 years ago, they were one of the worst populations of health in the world. It's like, we can't make this any worse. We're one of the worst in the world. They were at the low 5% of all health outcome HTA scores. Now they're in the top 75%, and in many cases, 90% of all HTA scores. And the most amazing part of their whole story is they spend about half as much on total health care for their 70,000 Alaskan Native people than we do in the rest of this country. That's pretty significant. Okay, next. So what did they do? They built, as the architecture of this amazing healthcare system, a massively powerful primary care system. They took primary care providers and they created a team. They gave them a small panel, just like ChenMed, and they said finding the correct diagnosis and creating the best treatments are secondary to the real work of partnering, encouraging, and supporting in personal relationships over time. When medical treatment is required, their commitment from the top is they'll get uncompromising, or they demand uncompromising perfect care, uncompromising demand for perfect care that is delivered in a perfect way for every Native Alaskan person every time. And that primary care team that gets to know every single member in their panel on a personal relationship based is the contact for all healthcare. And that patient or that customer owner simply calls their primary care team, and that primary care team coordinates all their care at all levels of healthcare. Imagine if healthcare worked that way. Next. Now, I haven't said anything about mental health, and yet I've said everything about mental health. There is nothing more powerful to manage the mental health of any population than a relationship-focused, behavioral-based healthcare system wrapped around the customer. Next. There's a couple of very important mental health statistics that I don't think enough people understand. The average delay between the onset of mental illness symptoms and treatment is 11 years. And 57% of adults with mental illness never receive treatment. Next. Just look at that and start to wrap your head around that. That means that for your populations out there, it's not until the 11th year that people begin to reach out, whether it's their EAP, whether it's their providers in therapy, People wait 11 years before they even reach out for help. And when they do, only 43% reach out for help. That is a huge group of population in this country that are suffering from emotional problems and issues that are not getting help because our healthcare system is not built really around them. Next. If we're only going to focus, if our goal is to only provide medical treatment and only to those who reach out for treatment, we're only going to address that much of the problem. And yet mental health and behavior is the root of almost every healthcare problem. Almost 90% of everything we spend in healthcare can be traced back to behavior. And the solution that's been proven over and over and over is that early intervention strategies are the key. We have to change our paradigm. Next. So what are those early intervention strategies? Well, just like Nuka and just like ChenMed discovered that integrating behavioral health with primary care is critically important. The other thing that I've discovered is incredibly important is engaging individuals in a behavioral focused coaching experience. Next. So integrating behavioral health with primary care. Now, I'm not talking about just any primary care. Let me just talk a little bit about how broken our healthcare front door is. When I ran hospitals, I might ask, why do you think I bought primary care practices? It was for one major reason. It's the funnel source into my hospital. I can make sure that somebody comes and gets my $5,000 MRI rather than going across the street to an outpatient imaging center for the same MRI for $300. We buy up medical practices, whether it's primary care or secondary, to be a funnel source into the broken system. The most important thing that employers can do to switch that and to start to move that is to engage subscription-based advanced primary care where the primary care is not bought up by the healthcare system and they're aligned with the employer to keep people healthy. And you can't force your members into that setting. And so the best way to move your members into that setting is to give them the choice. Say, look, I'm willing to pay for you to have this, but I'm not going to force you into it. The only way you get this money is if you're willing to participate in this. Next.
Yeah. Cheers to that.
So the other intervention strategy that's so critical is engage your population in a behavioral focused coach. The biggest problem with mental health is the stigma associated with mental health. So the best way to get over that is you engage people with a coach. And when you engage people with a coach, and it's about helping them reach their aspirations or an aspirations concierge, meaning I'm not here to tell you what to do. I'm not here to tell you how you need to change. I'm here to help you reach your own aspirations. You tell me what you're struggling with, whether that's finances or a career or physical or emotional health or mental health or nutrition or my environment. Doesn't matter what it is you're struggling with. Build a trusting relationship where the person's willing to open up about what they're challenged with and then support them as an accountability partner in reaching their own goals. One thing that I learned over the years, you can't change anybody to do what you want them to do, but you can engage people in making the changes that they want to make by supporting them and showing them the third party can be a tremendous support in doing that. And then engagement. So how do you get engagement? Well, incentives. I'll go to the next slide. When you look at behavioral science, there's two very important aspects you have to understand. Go to the next slide, please. And that is, and Daniel Pink says this as well as anybody. Most of you have probably heard of Daniel Pink. He's a well-known author and speaker in behavioral science. And he says it so well. Extrinsic, if-then rewards. Like if you do this, I'll give you some money. Or if you do this, I'll give you recognition. Are extraordinarily effective at simple, short tasks. They're great about getting someone to do a simple task. And they'll work almost every single time. But they're not effective at moving or more complex creative work for longer term horizons. In other words, you can't use incentives to engage people in real meaningful lifestyle change. But if you offer incentives to engage people in a relationship with a coach, you're using best practices of behavioral science to get people engaged with a coach, And then it's the relationship they build with the coach and the relationship of trust that they build that then engage them into change, as well as using the therapy that provided. Next slide, please. And the higher the incentive, the higher engagement. We're seeing companies get as many as 90% of all their employees and spouses engaged in a coaching relationship, low cost. You don't want to use a doctor to be everybody's coach, but a low cost behavioral focused coach. You can use if-then rewards to get them engaged with the coach, but then the actual change comes because of that relationship of trust. Next. So it's about meeting people where they are, build genuine trust and relationships, help individuals live life to its fullest. And then this is what's so key about mental health. The coach becomes a catalyst at engaging people in early intervention, because through their relationship, they help people get over the stigma of mental health. That's the key. Next. So we use a non-mental health provider like a coach and a non-mental health survey to survey the population and identify people who are struggling so we can proactively engage them in services. Next. A good example of a non-mental health survey is a well-being pulse survey. Send it out every week. Some employers send it out once a month, but a lot of employers send it out once a week. And within less than 10 seconds, people can share where they are in each of the 8 categories of well-being: social, emotional, environmental. And then that becomes an important element to then reach out to those that are struggling. And employers can actually have a dashboard that shows where they are. Where is their population divided up by their departments? Where are our people in their overall health? Next. So proactively addressing problems through emotional well-being, social well-being, relationships, and loneliness are all incredibly important. And coaching is an incredible way to drive people into that, help them over the hurdles of the stigma. Next. So to summarize, we've talked about you have to ask the question, what do you want? If you continue to just want to pay for medical treatments, you'll continue to see your healthcare costs go up. If you want to enhance health, you can drive your costs down by 50%. Behavior trumps science when health is the goal. And finally, mental health, it's about early intervention, integrate with primary care and engage individuals in a behavioral focused coaching. And of course, apply the best practices of behavioral science. Use short-term if-then rewards to get people into a relationship with a coach, and then use the coaching relationship of trust to drive behavior change and engage people in mental health. And that concludes my presentation, Lee.
Wonderful, Daryl. This is a ton to sink in. Some questions. If we have and I might butcher this, but I'm going to do my best. If we've got a limited incentive or a limited amount of incentive that we can use to try and get our members to walk the first mile to somewhere or something, should we try and direct them to a mental behavioral health coach, sort of a subclinical service, or should we try getting them into primary care, especially if it's advanced primary care, direct primary care?
Well, I would say that because of the huge, enormous barrier that the word mental health has, or a mental health provider has, use a term like primary care or like coaching. Drive people into something that doesn't have the stigma associated with it, but who are trained at then helping people get over the stigma and into proper mental health therapy.
So steer them towards, if you have to choose, steer them more towards like a primary care or getting that provider, or drive them right into the kind of the behavioral coaching?
Well, I would say both are effective, but primary care generally does not have relationships that are ongoing. Why is it that NUCA and ChenMed were so successful? Because they were meeting with their people on a regular basis. That's going to come more with a coaching relationship than it is with primary care. So if what you want to do is build trusting relationships with your membership, where people are able to actually open up about their problems, a behavioral coach that's going to be a lot less expensive than primary care is going to be a lot more effective at getting a lot of people over the barriers of mental health.
That makes sense. Uh, for the coaching standpoint, does ChenMed and the NUCA system, do they employ coaches to sort of offer both the coaching type service? Oftentimes that'll be a social worker, as well as having physicians who are kind of the MDs, or are they, outsourcing, or are patients getting that kind of coaching support somewhere else?
So those two models, which handle very high risk populations, have literally taken primary care providers who go through the normal training of how to pass on their information and all the medical science, and they send them through extensive behavioral coaching training. And so in both of those cases, they are engaging each member with a coach, but that coach is a medical provider that's been trained to be a coach. Now that can be very expensive for a large organization to try to deploy. Plus, how are you going to find physicians that have been humble enough to go through extensive training like ChenMed does or like NUCA does to become coaches? That's just not reasonable. That's why partnering a direct primary care provider with a coach that's lower cost, but's trained in motivational interviewing, behavioral change, empathetic listening, the skills of building trusting relationships, is a much better, effective, and practical solution for an employer.
Across HTA, we've got around 5 million lives of the families that we're working with. What kinds of tools might we use to be able to meet that need? I know there are vendors, but can we use can we use like an Accolade or a Quantum Health or a Right Way to do this kind of a service? Or should we focus on our primary care providers or advanced primary care? We are deploying a direct primary care, advanced primary care program initiative all across the country right now. Should we work with those providers and include this as part of the mandatory expected schedule of services? What would you recommend?
That's a great idea. If you can actually drive members into direct primary care and partner them up with behavioral focused coaching, that would be ideal. But I would encourage people to think about the fact that what you're having to do in order to really create effective healthcare is, like in the case of ChenMed and NUCA, completely transform the way you think about healthcare. What did NUCA do to really create half the cost and better population health? They sat back and literally transformed the way they thought about healthcare. And that's a difficult thing for a lot of employers, to really say, okay, I'm spending all this money through a broken system. How do I completely transform what I'm spending to get what I truly want?
Have you seen any employers, maybe you could share a story or a use case, who successfully made a transition like that? And it may be that it might be smaller employers that have done something like that. It might be hard to do at 100,000 lives, but
yeah, there's multiple cases where employers have literally done that. They said, look, it's more important for us to take our money we're already spending, put it into incentives to drive people to work with a coach on a regular basis, provide direct primary care, have this catastrophic policy, have this traditional health policy in place, but really drive our money towards massively powerful, effective primary care to drive behavioral change. And they're spending between $5,000 and $7,000 per employee versus $13,800 per employee, which is the average across the country. So they're spending half as much by putting their money into a whole new model of healthcare.
Well, that's great. That's fascinating. Also, other questions from the group. Feel free to hop in and or put them in the chat. As for the sort of the pulse survey, are there any resources or anything like that you've seen used and or examples of how companies have used that type of technology?
We are seeing these pulse surveys being used fairly regularly within human resources departments. It's becoming more and more common for human resources to want to get a pulse on their population. And I would say the nice thing is that it really is. It's almost more important to get a pulse on your population than an extensive survey once a year on your population. Finding out kind of where the group is trending is more important. Yeah. And that trending can be both in terms of well-being. And by the way, our technology we give away, we say it's free. We won't even charge you because we want you to have that kind of resource. But also to be asking your employees about how well do our benefits work to attract and retain you? How well are they working to drive better health? How are they working to give you what you want to why you want to work here?
Interesting. Do you find that most employees, when they're surveyed, I would guess most people don't know a lot about their benefits. What they do know, they may not like because they're expensive. And so people tend, even if you have even if they're not expensive, they're still complicated. And most people don't like what they don't understand. And so consumers often will gripe even about great benefits. They'll gripe about them. I'm curious if you've seen that pattern emerge as different employers. I'm guessing if someone's using your technology at no cost, you're still able to see the results as they come in.
Absolutely. But the most important thing is that you apply the basic principles of continuous quality improvement. So it's not just important to measure it. The key is to then use those measurements to show improvement. What's amazing is when you apply those principles of CQI, you can actually provide benefits that are far more simple for people to understand, far less expensive, and make this whole experience of benefits far less complicated. And by applying CQI and the fact that you're actually monitoring over time and you're making constant improvements, that's the goal. The problem in healthcare is that the buyer seldom monitors how well their benefits are even working to accomplish what they want.
I got to tell you, this has been incredibly inspiring and hopeful. And kudos to Lee to put us on this track for moving towards direct primary care. It really is hopeful here. But is there any way, this is a pipe dream, of getting in front of an actuarial team that shares with our CFOs and our CHROs what the trend will be if we do make this transformative change, where there be a willingness to show that 13 over time goes to 7 and have that, because with that, the market changes.
Well, the very best actuarial data is the two I shared with you. There's no question that NUCA, and they're willing to share all their data with everybody. It's, they're like, we'll tell everybody. Problem is that who goes to learn? It's Sweden and Singapore and Finland. It's like, we're not even going to our own backyard to find out what they've learned over 20 years. So there's the best actuarial data is right there. And then ChenMed and companies like
It's really important for us to consider, to demand that as we are introducing this DPC or direct primary care solution, that we ensure that whoever is producing the self-insured premium rate, that they do put in those type of expectations. If that happens, this goes in very easily. If it doesn't, the costs are going to go up. DPC is more expensive. I am a DPC user. I can absolutely substantiate all the things that you've said. It's a relationship. I've never frankly felt better about my own personal health care since I got a DPC. So anyway, I think that's key to our success. But again, a lot of hope here. I really enjoyed your conversation, Daryl.
Thank you.
Here. Daryl, we'll get Daryl's contact information out to everyone as well. I know we're over time. Thank you everyone for joining today in our second quarter behavioral health webinar, and so excited to continue learning and get better results taking care of our people. Thanks so much, everyone. We'll talk soon.
Thanks, Lee.
Thanks. Bye.
Well done.